Chapter 41, Common Psychosocial Care Problems of the Older Adult. These are the theory and clinical objectives for this section of the chapter. Okay, so some common misconceptions when we talk about our elderly adults and psychosocial issues is that all elderly individuals may be forgetful, have some mental confusion, or things like that. Um, not all elderly patients have, some type of memory impairment or whatnot. Elderly patients are very capable of learning new things, but they may take a little bit more time, or just be slower at learning new things. Now, when we do talk about our elderly individuals, there are some common conditions that might cause memory impairment, but it's not just because you're an elderly patient that you have a memory impairment. Some common issues that might cause some type of memory impairment or alteration in cognitive function of the elderly might be issues with dementia, different metabolic disorders that they might have, stress. A lot of times, our older adults have issues with alcohol abuse, or a lot of our older adults may be taking different medications that interact, and so maybe there's some um, undesirable medication effects. They also may have some, it's not that they um, have cognitive function, but their vision or hearing impairments might prevent them from being able to uh, do or learn different things as well. Okay, so like I said, confusion or whatnot, cognitive impairments is not because the person is getting older. There's a lot of different things associated that can cause confusion in our elderly patients. For example, if they have issues with vascular insufficiency, tumors, trauma, central nervous system infections such as meningitis, hypotension, different systematic disorders such as sepsis. Maybe they had some type of infection, like a UTI or respiratory infection or something like that, that may be causing some confusion. Metabolic or electrolyte imbalances, like I said, drug toxicities, nutritional deficiencies. Maybe there's stress, maybe there's pain, endocrine disorders, anxiety, dehydration. All these different things can lead to confusion in our elderly patients. And these things are not necessarily just associated with the patient being elderly, but because of issues that they might might have. So when we have significant changes in a mental function, we want to make sure we include a comprehensive mental status exam. You want to do a detailed and accurate history and physical exam should be performed. And when you do this, you want to make sure you allow your patient enough time to respond, because they might be slower to respond to your questions. So just make sure you're giving them enough time, and don't ask one question, second question. Give them time to respond to um, each question. Um, make adjustments for any sensory limitations that they might have, such as vision or hearing issues that they might have. Some questions that you may want to ask are, what did you have to eat this morning? What year is it? How do you cope with stress? How often do you go out with friends? What's your birthday? What's your anniversary date? What's your address? So things like that are when you're asking questions, trying to do a mental status questionnaire on these individuals. Um, Assess for factors that can contribute to their altered mental state as well, such as making sure you do a thorough medication assessment. Are they in a new environment? Do they have different disease processes going on? So you want to make sure you assess all those different situations that could be contributing to the confusion as well, because we want to know what types of interventions we need to put in place to try to alleviate any confusion that may be new that they're experiencing. So when you have a patient experiencing confusion, there's a lot of different things you might see in that patient. They might have some difficulty remembering different things or learning, difficulty learning things. Maybe they have some difficulty following directions or communicating their needs. They could have some personality changes as well. And so you want to make sure you assess what is their support system as well. And also making sure you, like I said before, understanding any underlying conditions or chronic comorbidities that they might have, and how is it impacting those issues as well, because patients that are having confusion, maybe they're not following their stated regimen, such as their diet or medications or different things like that. So we want to make sure we assess their support system um, and their ability to continue to be able to take care of themselves. Okay, so when we talk about delirium versus dementia, um, you might see some of the same symptoms, but they're different. Delirium is a state of confusion, and so it's characterized by a sudden onset. In most cases, it'll be short term as well. And so the person might have anything from being anxious to agitated. They might be fearful, apathetic, or things like that. So, like I said, with a person with delirium, um, it's acute, meaning it comes on all of a sudden, usually exacerbated by some type of situation. So, for instance, in our older adults, if they were to get a UTI or some type of infection, then they might have delirium. Um, if you had some metabolic imbalances or electrolyte imbalances, um, different drugs, can cause delirium. Maybe if you go under anesthesia or different narcotics that you might be taking. And so, like I said, it's a sudden onset, and the person is probably going to be disoriented, have a cloudiness uh, in their level of ability to make judgments and things like that. They might be agitated, maybe have some difficulty remembering things. But the thing with delirium is once we resolve that particular issue, then the delirium itself um, will be resolved. And so, then they'll go back to, their normal state once so delirium, unlike when we talk about dementia, delirium is reversible. Another thing I want to make sure you uh, understand is about sundown syndrome. Now, with sundown syndrome, um, a lot of times patients during the daytime hours will be fine, but as we start to get to the evening hours, early evening and nighttime, then they become highly confused, more agitated, um, as and this is called sundown syndrome. And so we want to make sure a person that experiences sundown syndrome, we put any activities that they might have during the daytime hours. And so when we get to those early evening hours and nighttime, we want to start to decrease the stimuli that person, may be having, so that they can start to calm down and relax when we get to the evening hours. Now, dementia, on the other hand, usually has a slow onset and it's going to be uh, irreversible. So we have a lot of different types of dementia. And it's just basically based on what is causing a dementia. For example, our most common type of dementia is Alzheimer's, which the exact cause of Alzheimer's is not necessarily known, but a lot of things can be risk factors such as older age, or maybe you had some head trauma or something like that. When they look at the brain on a person with Alzheimer's, that the frontal and temporal lobes of that brain might have some decreased neurons. But some other types of dementia that a person could develop could be vascular dementia, AIDS dementia, um, Korsakoff's dementia, which is from alcohol. Um, People that were alcoholics develop a type of dementia. But understand with dementia, unlike delirium, dementia is permanent and it cannot be reversed. Now, can dementia and delirium coexist? Yes, they could, because if you had a patient that had dementia, and say an elderly patient with dementia, and then say they developed some type of urinary tract infection or some type of infection, and that caused delirium, and so there would be still something outside their normal um, baseline behavior that's happening, some type of confusion that's outside their normal baseline. And once they clear up that issue or whatever was causing the delirium, then they would go back to their baseline dementia. So the two can coexist, but remember that these two are different, they're not the same. So, how we approach these individuals that's having some type of confusion or disorientation, whatever it might be from, um, is going to make a difference. And so, our goal is we want to be able to produce a feeling of well being in the confused or disoriented elderly patient. And so, some things that your book talks about that we'll discuss in the next few slides here are reality orientation, validation therapy, reminiscence therapy, remotivation therapy, and resocialization. Okay, so when we talk about reality orientation, that's keeping your patient oriented to time, place, and person. You want to make sure your interaction with them, you're not giving them a false reality. You're not, uh, you know, falling into their false reality. If they say, "Oh, mom's coming to visit me later on this afternoon," and mom's been dead for 20 years, we're not going to fall into that and say, "Oh, I can't wait to meet her." No, we're not going to do that. We want to keep them. Now, you're not going to go say, "Oh, mom been dead." We're not going to go ahead and try to dredge up feelings. Maybe you could turn that around and say something like, "Oh, you seem to have loved your mom. Why don't you tell me more about it?" Or something like that. But we're not going to fall into that false sense of reality. So we want to make sure we keep them oriented to the current time, place, and person. And so we can have clocks up to keep them oriented to time, clocks or calendars around so that they can always see what time it is. Or, I always say in long-term care facilities, bingo's always at 2 o'clock. So they know if it's time for bingo, it's got to be 2 o'clock. TV, maybe there's a TV show. Maybe they like to watch the news. If you turn the news on and they know, oh, it's 6 o'clock because the news on the TV, or something like that. Keep scheduled meal times, schedule activities or whatnot, so that they can stay reoriented. So if their normal time to get up at 7, and we're going to keep them on that schedule. If breakfast is at 8, we're going to keep them on that schedule so that they can stay oriented to time, keep oriented to where they are, the place where they are, and themselves as well. Okay, validation therapy. So with validation therapy, we're trying to decrease their stress and promote self-esteem and communication within this individual. And so you want to acknowledge the person's words and actions. You want to do that with respect and empathy, and not trying to embarrass them. Don't try to embarrass them or cause anger. Don't try to dismiss their feelings. Don't be dismissive towards their feelings and the things that they say. If they say something that doesn't make sense or whatever, you're not trying to embarrass them or whatever. Sometimes group activities, group support can help encourage their feelings or whatever. So we're trying to validate them, validate their feelings, and make them feel um, uh, uh, less stressed and improving their self-esteem. Okay, reminiscence therapy. So with reminiscence, what we're trying to do is get the person to re-examine the past to promote socialization and mental stimulation. And so you're gonna maybe encourage the person to share their life experiences. It could be a one-on-one situation. It could be a group situation where they're, sharing, going down memory lane or whatever. Maybe you're going through a photo book with them or whatever, and then you ask you ask questions about the photos in their photo book, and allowing them to share their past experiences, share their life experiences with them, encouraging them to reminisce about the past, right? And so listening to them share these past experiences helps elderly patients feel more appreciated and comfortable, and it gives them an opportunity to be able to express their emotions as well. Okay, remotivation therapy. That's just that. We're remotivating them. So, trying to stimulate the senses and provide new motivation in life. And so, you know, if the person enjoyed gardening once, then encourage them to go out in the facilities garden and talk about the plants and the flowers and gardening and what they used to do. Get them more remotivated. If they were interested in art or music, then put them in that setting and allow them to get remotivated um, or whatnot. Okay, and resocialization, trying to get them to um, socialize more. So you want to encourage socializations within groups. We mentioned earlier, bingo's always at 2 o'clock. Can we get them out to, some of these activities to socialize um, uh, as well? Maybe we can. We got different activities. Maybe if you assign different roles to different people to do things, maybe this week you set up the refreshments, you help activities set up the refreshments, or this week you help activities, set up the games or whatever, trying to get them back out into socializing more with people. So that's re-socialization, just what it says, trying to get them to socialize and be involved. Okay, also, sometimes dealing with patients with confusion and disorientation, depending on how bad it is, we might need to use some type of medication or pharmacotherapy to try to help calm them down. Maybe you have to use some tranquilizers or antidepressants, things like that, to help control their anxiety or their agitation, or even if it's paranoia. A lot of these things can be associated with dementia, and so they may be taking some of these things to help with that. But keep in mind, these drugs do have different side effects, and so you want to make sure you're monitoring your patients closely for these different side effects. If they do live at home with the families, then make sure the families are educated on how to properly administer these medications, as well as the side effects these medications may have on the patients as well. Okay, so caring for patients at home can be extremely stressful on families as well. And so they need, a lot of support and a lot of referrals, a lot of education, a lot of assistance. If they are in a facility or whatnot, make sure the family is included in the care planning process. If they are at home, then make sure they understand, about respite. Maybe you can give them a referral for respite, a respite referral. And so respite is, say the family wants to go on vacation. Obviously, they can't leave their loved one with dementia at home alone. Then respite is a place where they can, take the loved one to be cared for while they're away on vacation. Or maybe they just need a break. Maybe they're not even going on vacation, but they just need a break or something. And so respite is, like I said, a place where they could take their loved one for a week or two or whatnot. Um, so that they can, get that break or do some of the things that they need to do. You can also provide referrals for different support groups or different agencies that provide companion services. Maybe they need referrals for community services like Meals on Wheels, local adult daycare centers, things like that. So make sure you're giving the family the support that they need as well, because it can be, really difficult and stressful on them as well, caring for these individuals at home. Okay, so like I said, the most common form, there's lots of different types of dementia, but the most common form of dementia is Alzheimer's. And like I said, the cause of it is not really known, but it is, more common among your elderly population over the age of 65, individuals over the age of 65. And when they look at the brain of a person with Alzheimer's, there is a loss of neurons in that in the frontal and temporal lobes. So people experiencing Alzheimer's, they could have a variety of different issues going on, from cognitive impairment to malnutrition, decreased fluid intake. Maybe they're not sleeping properly. Maybe there's some frustration trying to perform different activities and things like that. So we're going to talk about the different stages of Alzheimer's as well. Okay, so for Alzheimer's, we got three stages: our early, middle, and late stage. In the early stage, you might start to see some mild short term memory difficulties. Maybe they start having difficulty learning new things. They might start to, because they're noticing these things are starting to happen to them, they might have some mild depression. Then, when we get to our middle stage, the memory loss increases even more. So there's even more short-term memory loss, but then even their long-term memory starts to get affected. Maybe there's more agitation or hallucinations. Maybe they start having difficulty performing some of the ADLs and start needing assistance performing ADLs. They start to wander, become incontinent. Now, individuals that start to wander, these were people that were usually probably pretty active in their earlier days. They were probably active people if they start to wander. And so if you've got somebody staying at home with their family and they're wanderers, we talked about providing support to the family. Maybe you could try like alarms or something, because if we're asleep, we don't want our loved one wandering off in the middle of the night. So if they get up and start to go towards the door, an alarm would sound that would wake the family up. So that could be something, we could do for those individuals that are wanderers. Also, making sure you sew their names in their clothes. So if they did get away somewhere and someone found them, their names would be in the clothes or whatnot. Usually, the early stages could be anywhere from 2 to 4 years, and then your middle stage could be anywhere from 2 to 12 years. Um, also in that middle stage, difficulty driving a car might become issues as well. Okay, so for our late stage Alzheimer's disease, now this is a disease that's going to progress until eventually the person will die. And so it could be difficult watching your loved one go through each of these phases. And then once it gets to the late stage, they forget everything. They forget how to eat. They forget how to um, walk, so they could become bedridden. And because they are not eating properly, then they might start to lose weight. And so they forget how to swallow, difficulty swallowing, and they're going to forget their loved ones. They won't remember who their loved ones are. Um, and like I said, it's just going to deteriorate until eventually the person does pass away. And so this phase could last anywhere from um, 2 to 4 years or so when we're talking about late stage Alzheimer's. So we want to make sure we're doing things to promote nutrition. Maybe they need a peg, or um, we're providing, that incontinence care if they are bedridden. Maybe we're doing different range of motion exercises with them to try to prevent contractures and things like that for these individuals. Okay, so like I said, when you start to have patients with increased mental impairment, um, some strategies, especially if they're staying home, like we've talked about, the alert systems that's attached to the door. So if everyone in the house is asleep and they start to get up to wander, then it will alarm to alert, everyone that the person's going towards the door, something like that. Their names sewn in their clothes or whatnot. So if they did get away, someone would be able to identify them. Um, at some point, the family, you may have to talk to the family about residential placement if it gets to be too much for the family to handle. Like I also said, driving may become um, an issue when we get to, especially when we get to moderate stage dementia. And so, driving is one thing that our elderly patients don't like to give up. That's their independence, and they don't like to give that up. And so, depending on the degree of their ability to drive, maybe we could limit driving to daytime driving only, or if we have to stop them from driving all the time, making sure someone is available to take them wherever they need to go so they don't feel like, oh, I'm trapped here, I can't go anywhere, or whatever. So making sure they have the ability to get to wherever they need to or want to. Maybe we set up uh, uh, so for them to be able to ride shares or whatever to go where they need to go safely or whatnot, so that they just don't feel like, oh, they've taken my driving away and now I can't do anything or go anywhere, because like I said, that is one of their big independent things, that, and they don't like to give that driving up. Okay, so um, if the patient does have increased agitation or hostility, um, usually a lot of times it might be preceded by increased irritability. So they're gonna maybe have some type of explosive outburst if we don't redirect. Um, they might start talking louder, might start pacing. These are all some things that you want to make sure you're monitoring for, watching for these signs and symptoms, so that you know that you need to do some type of intervention or something. So safety is going to be a priority, safety for the patient and safety for any other patients or visitors that might be around in that particular area. So distraction might be something that you can do, trying to distract them. You want to make sure you maintain eye contact. You don't want to just go grabbing on people. Let them know what you're going to do before you do anything. Call them by their name. Stay calm. You want to stay calm. Don't you get upset and agitated and start yelling and things like that either. Um, you want to use simple, direct statements and directions. Um, Keep the background noise to a minimum, um, and things like that. For people that are having some type of paranoia, You want to remember, I said, keep the reality, develop a trust with them, try to develop trust and relationships with them. And so you develop, so if you know they have that, then you want to develop trust and relationships ahead of time. So you can develop trust and relationships by being consistent, being reliable, um, to try to start developing that trust and relationship with that person. So when they do have an episode, they're more likely to trust you and trust what you're saying. Okay, so like I said, people that start to wander when we get to the moderate stage Alzheimer's tend to be people that were pretty active in their previous years. And so, some things we want to do, we, obviously, safety is always going to be our priority. So, make sure the environment is safe, um, if they do start to wander. Um, like I said, they could do the ID ban or making sure their name is sewn in their clothes or whatever. Checking on the patient pretty frequently. There was a situation at one nursing facility a few years back when it was when Ohio had several cold days, below zero cold days in a row, and the facility had this one particular Alzheimer's patient that was a wanderer. The patient wandered outside, and no one noticed for hours. And by the time they actually found the patient, she had developed frostbite so bad that she had to have a leg amputated. So you want to make sure you're checking on your patient regularly. Observe for any behaviors that might trigger the wander and try to distract and divert the patient's attention. Keeping them involved in different activities as well can be helpful for these individuals. Okay, so like I said, sundown syndrome is when the patient has changes in behavior in the late afternoon or early evening. And so they start to have more increased confusion, more agitation, things like that. So in your book, Box 41.6, it goes over some strategies to try to minimize sundowning, such as limit outings and activities to the morning hours for the persons with Alzheimer's disease, keep times of sensory stimulation short. So, prevent sensory overload, such as television or noisy children, things like that. Keep them to a minimum in the evening. Maybe using a night light, making sure the call light's within reach, making sure you're answering that call light in a timely manner. Um, like I said, reduce the stimulus in the environment. Move the patient closer to the nurse's station. And always, um, remember, um, any protective devices like restraints or whatever, those are a last resort. That's a last resort. Just because someone's sundowning or becomes agitated or whatnot, the first thing we do is not put restraints on a person. And restraints can be chemical or they can be physical. Chemical is if you've given them a drug to calm them down or keep them quiet or keep them from moving or whatever, that's still considered a restraint. Restraints are false imprisonment. And so even so if I had a wrist restraints or something like that on them, um, then I want to get a doctor's order for that. And it can't be a PRN order. It has to be an order that you're getting renewed every day, because you should be assessing that person every day to make sure those restraints are still needed. If you do have on wrist restraints, you need to be releasing them every couple hours, checking for um, any breakdown, and providing range of motion and things like that. And we're constantly reassessing, do they still need to have these restraints or whatnot. Okay, so like we've said, sometimes patients with cognitive disorders might have some nutritional challenges, because they're not eating properly. Maybe they don't have um, appetite. Maybe they um, just refusing to eat. Maybe they pocketing food, holding food in their mouth, refusing to swallow, or choking when they swallow, different things like that. So we want to make sure we're providing good oral hygiene and inspecting their mouth. Make sure there's, no sores or issues in their mouth. Sometimes just providing companionship during meals can be helpful to these individuals. Identify what's their hungry time of day. And so we're feeding them at that time. Provide small meals. You don't want to do big meals and expect them to sit and eat a whole big meal. Give them some of their favorite foods. Remind the patient to chew. Sometimes, with cognitive disorders, they simply just forget to chew. So reminding them to chew. If they need assistance with feeding, then help them. Then feed them, if that's what they need or whatever. Okay, an acute confusional state that can occur suddenly or over a long period as a result of an underlying biologic cause or psychological stressor. So the answer here is number one, delirium. So remember, delirium is an acute confusional state that occurs suddenly, whereas dementia um, occurs over it takes a longer period of time um, to occur, and it's long term. It's not short term. Question two. Maggie's patient has symptoms of confusion and begins to get agitated in the late afternoon. This condition is known as, so the answer here, remember, is sundown syndrome. The patient with nocturnal delirium is sundown syndrome. These are the theory objectives for the next section of this chapter. Okay, so depression is a real issue among elderly patients, and if it's not treated, it could lead to things like alcoholism and suicide. So a lot of our older adults, they've had a lot of losses in their lives. Maybe they've lost children, maybe they've lost a spouse, just lost their job, they're no longer working. So there's a lot of different losses that they have encountered. And so this can lead to depression, which in turn can lead to alcoholism, and suicide is very common among our elderly patients as well because of this. And so a lot of times elderly patients with drinking problems are retired from work and they're at home, so their alcoholism might be overlooked. So we want to, monitor for signs of, do they have depression, insomnia, mental confusion, frequent falls, self-neglect, uncontrolled issues such as their hypertension, their diabetes, or things like that being uncontrolled. So we want to make sure we look for those type things. And so because the alcoholism, it can interfere with, their chronic diseases. Also, think about too with our elderly patients, their kidney function and their liver function is going to decrease. And so if they're drinking large sums of alcohol, it's not going to be excreted from the body as well. And so that's going to cause, more issues. Okay, so different interventions to treat depression or alcoholism and suicide. Maybe they need some type of antidepressant. Once it's diagnosed, you can do antidepressants or electroconvulsive therapy. Electroconvulsive therapy is like it's a brief electrical stimulation of the brain while the patient's under anesthesia. Maybe they need some counseling or, crisis intervention depending on, how bad the situation may be. So the main goal with depressed patients is to prevent them from causing any self-injury. And so, some signs that a person might be considering suicide is maybe they start giving away their personal belongings, or they suddenly become happy, or they start getting their affairs in order, or something like that. Might be some signs that a person is considering self injury. A lot of times people have said, you know, I had no clue. We had dinner that night, we were laughing and talking, and and then they just had no clue. So then they all of a sudden become happy. Okay, so remember, as nurses, we are mandated reporters for elder abuse. So there's a lot of different types of elder abuse. So as a mandated reporter, it doesn't mean you have to have proof. It only means you have to suspect it. If you suspect it, then you need to report it to the proper authorities. Um, you don't approach the person that you suspect. You don't um, investigate yourself. It's not for you to investigate. You only have to suspect it. And if it comes back that something happened and you suspected it and you didn't report it, then you will be in trouble for not reporting it, because as a healthcare worker, you are a mandated reporter for elder and child abuse. So, different types of elder abuse, you've got physical, sexual, psychosocial, material, and neglect. When we talk about physical, that's actually what it is, physical. So the person has some physical pain or injury, um, you know, from assault and battery. So maybe they're being hit. So you notice bruises or fractures or scars or whatnot. Sexual assault, yes, elderly individuals um, can be sexually assaulted as well. Psychosocial assault, that's verbal harassment. So that can include being intimidated, intimidation, defamation, isolation, can all be included in psychosocial or psychological, I should say. Abandonment, that could be a type of psychological assault. Material, that's when their money or their belongings are stolen. And then neglect. Neglect is failure to meet the needs of the older adult. So that could include leaving the person alone, withholding their medication, withholding their food, or other things that they need for survival. Okay, so older adults are prime targets for a lot of scams that people try to commit, telephone scams especially. So you want to educate your patient not to give out their personal information, such as their social security number, their credit card, or whatever. Don't get that information out over the phone. Don't tell people that they're home alone. Um, Make sure they, tell them to keep their doors locked, um, or whatnot. Lock their windows, pull their blinds down. Don't let people know that they're by themselves. So, making sure they're educated on, these things, because they are can be the target of a lot of different scams. And so, as nurses, you should probably learn about different referral programs around with crime protection and prevention and victim assistance to try to be able to refer your elderly patients if needed.